All right, so I would like to introduce our next speaker, Alice. Oh, okay, slides are coming. Allison is one of our nurse practitioners in our outpatient blood disorders and cellular therapy center here at the University of Colorado at the Anschutz campus. She received her undergraduate nursing degree from the University of Wisconsin in Madison and started her career as a bedside nurse in BMT and oncology after graduation. After that, she did some travel nursing and eventually landed in Colorado. She received both her master's as well as her DNP from the University of Colorado here at our Anschutz campus as well, and graduated just this past May. Woo woo! Big accomplishment with her DNP. She's also the co-chair of our Leukemia Disease State Committee, where she helps update our guidelines for our interdisciplinary team. And she is going to be doing the second half of my talk from this morning, which is our updates and our new therapies. So we were chuckling that we feel like there's been a ton of advancements, but then we watched everyone else's presentations and we were like, oh, maybe not quite as many, but there are a ton of advancements still for us to talk about in this space. So we're really excited to welcome Allison for her talk.
All right, so thank you, Meredith, for that introduction. So I'm Allison. I work in the outpatient clinic here at Anschutz in the Blood Disorder Center. So I have no relevant disclosures. Oh, yeah, I'm a little taller than Carrie. Yeah. Okay, there we go. So objectives today are to identify newly approved AML treatments, to summarize the monitoring and potential complications of treatment, and to explain targetable mutations in AML and the treatments available for those mutations. So I'll start with a case study. So SR is a 34-year-old female. She has no significant past medical history. She presented to the ED with dyspnea on exertion, fatigue, intermittent chest pain for 3 weeks, and some petechiae. Her labs on presentation, she had a white count of 41,000. Her hemoglobin was 10. Her platelets were 61. She had a bone marrow biopsy done, which confirmed a diagnosis of AML. Her FISH panel came back negative. And she did have a myeloid NGS panel that showed mutations in FLT3, ITD, NPM1, and DNMT3A. So we know that AML is a really aggressive diagnosis. So how do we decide on the treatment that's necessary for this patient? So first off, is she fit for intensive induction treatment with our traditional 7+3? So she's young, she has no significant past medical history. She had a pre-treatment echocardiogram. Her ejection fraction was 65%, and her other labs were all relatively within normal limits, so she didn't have a lot of end organ damage otherwise. Secondly, does she have any identifiable mutations? And yes, her NGS came back positive for that FLT3 ITD as well as NPM1, but more on that later. And then what are the risks of the regimen we would give her, and how would we anticipate her to tolerate that? So as Meredith talked about this morning, 7+3 is not an easy regimen for any of our patients, even if they're young, fit, without a lot of other comorbidities, still something we need to take into consideration. So the NCCN guidelines list the European Leukemia Net, or ELN, risk stratification for those with AML, which ranges from favorable to poor or adverse risk. And this can serve as a guide for how aggressive certain genetic abnormalities are and help guide the treatment decisions for these patients. So our patient case, SR, she falls into the intermediate risk category because she has mutations both in NPM1 and FLT3 ITD. So one of the most transformative changes to treating acute leukemias occurred when molecular testing was identified for those with AML. And this happened about 10 years ago. There was a push to identify these mutations for that may lead to the pathogenesis of AML in patients who otherwise had a normal karyotype, to figure out what the molecular abnormalities for these patients were. So the Cancer Genome Atlas Research Network looked into 200 cases of de novo AML, which means not secondary or treatment-related AML. And this was to identify common genetic mutations in that subset of patients. And you can see here on the far left that FLT3, NPM1, and DNMT3A are the most common mutations seen in AML, even though this data is 10 years old. Currently, however, there are only FDA-approved therapies for 3 of these targetable mutations, and that's FLT3, IDH1, and IDH2. So the approved therapies for those actionable mutations in AML, I'll start with FLT3. For FLT3, there are 3 approved therapies. Midostaurin is approved for FLT3, ITD, and TKD mutations. This is indicated in newly diagnosed patients, and it's used in combination with 7+3. It's added to the regimen on day 8. And it can also be used during cytarabine consolidation for these patients. Quizartinib is the newest FLT3 inhibitor, and this targets FLT3 ITD mutations only. This is indicated in newly diagnosed patients, and it's indicated for treatment during induction with 7+3, during consolidation, as well as monotherapy maintenance post-consolidation. Gilteritinib is approved for FLT3 ITD and TKD mutations for patients with relapsed or refractory AML. And this can also be used for post-allogeneic stem cell transplant maintenance. Moving on to IDH1, we have 2 approved IDH1 inhibitors. So we have ivosidenib, which is approved for newly diagnosed patients, and it can be used in combination with azacitidine or used as a monotherapy. It can also be used for relapsed or refractory AML. And then olutasidenib is indicated for relapsed or refractory AML, and it can be used as a monotherapy. And then for IDH2, we currently only have 1 approved treatment for that, which is enasidenib. And this is approved for relapsed or refractory AML in combination with azacitidine or used as a monotherapy. So FLT3 or FMS-like tyrosine kinase 3 mutations induce intracellular signaling pathways, which trigger leukemic cell proliferation and anti-apoptosis. FLT3 is mutated in approximately 1/3 of patients with AML, either by that internal tandem duplication, which is FLT3 ITD, or by a point mutation, mainly involving the tyrosine kinase domain, which is FLT3 TKD. FLT3 ITD mutations are present in about 25 to 30% of AML patients, and TKD mutations are present in about 5 to 10% of patients. Patients with a FLT3 ITD mutation historically have a higher risk of relapse and a poor prognosis overall. As I mentioned, we have those 3 FDA-approved therapies for FLT3 mutations, and that's quizartinib, midostaurin, and gilteritinib. And the FLT3 inhibitors work by binding to the FLT3 receptor and preventing it from being activated, which causes apoptosis, cell cycle arrest, and differentiation of that myeloid cell. So quizartinib was approved in July of 2023 for patients with newly diagnosed AML with that FLT3 ITD mutation. It can be given in combination with 7+3, cytarabine consolidation, and or it can be used as a monotherapy maintenance in these patients. Quizartinib works by selectively binding to the inactive FLT3 receptor, preventing the receptor activation and downstream signaling. We previously used midostaurin for FLT3 mutations in the frontline setting, which targets several more kinases, but it's not as selective as you can see by this picture here. Quizartinib, on the other hand, is a more potent and selective FLT3 inhibitor, and specifically only for those ITD mutations. So the study that led to the approval of quizartinib was the Quantum First trial, which enrolled 539 patients with newly diagnosed FLT3 ITD AML. The study enrolled patients up to age 75 and only those with a FLT3 ITD mutation because quizartinib only works against that ITD mutation. It was a randomized double-blind placebo-controlled phase 3 trial. And the study compared adding quizartinib to induction, consolidation, and maintenance phases of therapy when compared with placebo. So the Quantum First trial found an overall benefit and improved survival, where the median overall survival for treatment with quizartinib was 31.9 months compared to 15.1 months with placebo. So some safety considerations with quizartinib. It's overall well tolerated in studies, but does come with a black box warning of the risks of causing QT prolongation, torsades, and cardiac arrest. So to mitigate this, the clinician must monitor for electrolyte disturbances, specifically monitoring potassium and magnesium, and repleting these to keep these in a normal range. The quizartinib package insert dictates to not start quizartinib if the QTC is greater than 450 milliseconds. And monitoring should include obtaining a baseline EKG, then weekly EKGs after the first month after initiation and with any escalation of quizartinib. The clinician should also consider more frequent EKGs for those who are having anything like nausea, vomiting, diarrhea, as you might be more at risk for electrolyte dyscrasias. Of note, quizartinib must also be dose reduced with strong CYP3A inhibitors. So it's always a good idea to have our pharmacy colleagues do a really thorough medication review on these patients. And then other common side effects of quizartinib can include myelosuppression, increase in LFTs, diarrhea, nausea, vomiting, and mucositis. So the dosing of quizartinib during induction, like I mentioned, it starts on day 8 of induction, and that allows us also to get back that FLT3 panel to kind of confirm that someone has FLT3. And it's given days 8 through 21 during induction at a dose of 35.4 milligrams orally. During consolidation, it's given days 6 to 19, and again, it's given at that same dose. And then during maintenance, however, the dose is smaller than what it was during induction and consolidation for days 1 through 14. And then you'll do a EKG at that point, and as long as the QTC is less than 5 or 450, then that dose increases to 53 milligrams. So the question remains of whether to give quizartinib or midostaurin, and is one more effective for long-term survival and deeper remissions in these FLT3 positive patients. And these two medications have not been directly compared, so currently there's no answer to that. We do know, however, that quizartinib is a more selective FLT3 ITD inhibitor, while midostaurin inhibits both FLT3 ITD and TKD, as well as several other kinases. Next, I'll discuss IDH mutations or isocitrate dehydrogenase mutations. So mutations in IDH cause dysregulated DNA, which produces the oncometabolite 2HG, which alters DNA methylation, blocks cellular differentiation, and is thought to be leukemogenic. IDH mutations are present in up to 15 to 20% of AML patients, with IDH1 mutations occurring in about 6 to 16% of patients, and IDH2 mutations present in about 8 to 19%. Currently, there are 3 FDA-approved IDH inhibitors, 2 for IDH1 and 1 for IDH2. Today, I'll be discussing olutasidenib specifically, since that's the newest approved of the IDH1 mutation inhibitors. So olutasidenib was FDA approved in December of 2022 for relapsed or refractory AML with an IDH1 mutation. It's a small molecule IDH1 inhibitor, which reduces that 2HG production to restore normal cell differentiation. It's given as 150 milligrams twice daily on an empty stomach. And the package insert advises that for patients without disease progression or unacceptable toxicity, to treat these patients for at least 6 months to assess clinical response. So this was the study that was the basis for approval of olutasidenib, which again is that oral inhibitor for mutant IDH1. The study looked at olutasidenib as a monotherapy for 153 patients with relapsed or refractory AML with a median age of 71 years old and a median of 2 prior regimens before receiving olutasidenib. The rate of complete remission with partial hematologic recovery was 35%. and the median duration of overall response was 11.7 months, with a median overall survival of 11.6 months. Of note, olutasidenib has not been directly compared to ivosidenib, which is the other IDH1 inhibitor. So monitoring for olutasidenib, it does carry a black box warning of differentiation syndrome, which was observed in up to 16% of patients. It can also cause leukocytosis not related to infection, and there's a low threshold to cytoreduce with hydrea at the same time of the treatment. It can also cause hepatotoxicity, so monitoring for this is important. If it becomes a grade 3 hepatotoxicity, the package insert recommends holding the drug until at least it's a grade 1. And if it's a grade 4, they recommend to permanently discontinue the drug. Other common adverse effects include nausea, constipation, mucositis, fatigue, fevers, arthralgias, dyspnea, and rash. And then also with olutasidenib, patients should avoid strong or moderate CYP3A inhibitors. It also carries that black box warning for differentiation syndrome, like I mentioned, and this was observed in up to 16% of patients. So differentiation syndrome occurs when normal cell differentiation is restored, which is great for our patients, but it can also cause these adverse effects and can be deadly if not treated. So this can, when differentiation syndrome occurs, it promotes that maturation of those leukemia blast cells, which causes rapid proliferation and differentiation of the myeloid cells. This can then lead to extravasation into the lungs, skin, and tissues, which can manifest as shortness of breath, pulmonary infiltrates, kidney injury, hypotension, and weight gain. In patients who received treatment with olutasidenib, interestingly, this was observed anywhere from day 1 of treatment up to 18 months post-initiation of the drug. So if this differentiation syndrome is suspected, temporarily hold the medication and start on steroids. Here at our institution, that typically looks at something like dexamethasone, 10 milligrams every 12 hours, and they'll usually be admitted for close monitoring as well. And if there's simultaneous leukocytosis, there's a low threshold to start that hydrea therapy at the same time. So just kind of note, while all of these treatments are exciting in the world of AML, allogeneic stem cell transplant remains the only potentially curative strategy for most patients, except for those with favorable risk disease, such as core binding factor, where intensive chemotherapy followed by consolidation has the potential to be curative. So back to our case study, our patient SR, she received induction with 7+3, and she had quizartinib added on day 8 because of that FLT3 ITD mutation. Because of her intermediate risk, we know that she needs an allogeneic stem cell transplant. So she had a bone marrow biopsy performed before transplant, which showed remission with no increased blasts, and both flow MRD and molecular MRD were negative for FLT3, NPM1, and DNMT3A. So she proceeded with an allogeneic dual cord stem cell transplant. But given her intermediate/high risk disease, what could be next for her? So we know that this patient had intermediate risk disease at initial diagnosis. So our physician colleagues will often consider post-transplant maintenance for these patients. There are several risk factors that influence the post-transplant relapse in AML. Measurable residual disease, both pre and post-transplant, is a predictor of disease relapse after an allo transplant. For those who are pre-transplant MRD positive, there's a 2-year cumulative risk of relapse at 41%, compared to 20% risk of relapse for patients who are MRD negative pre-transplant, as was seen in the Figaro study. And those who were MRD positive post-transplant, there was a 5-year cumulative risk of relapse at 53%, compared to a 26% risk for those who were MRD negative post-transplant. Additionally, patients with an adverse risk molecular profile, that's indicative of a higher incidence of relapse post-allo transplant. And in this report, that was defined as mutations in TP53, those with a complex or monosomal karyotype, monosomy 7, and deletion 5. So all of these risks are factored into a patient's risk of relapse and can help guide post-transplant prophylactic maintenance treatment choices. To sum up those factors that influence post-transplant relapse in AML, MRD is an important predictor of disease relapse after stem cell transplant. Having an adverse molecular profile is also indicative of a high risk of relapse, and disease factors such as secondary AML arising from MDS or treatment-related AML are also a higher risk. And also patients who receive non-myeloablative conditioning regimens may also have an increased risk of disease relapse. So for those with a higher risk disease and or MRD positive prior to transplant, many of our physician colleagues will elect to proceed with post-transplant maintenance for these patients. And for those with a FLT3 mutation, the choice in post-allo transplant maintenance is often gilteritinib, especially at our institution. And the BMT CTN 1506 or Morpho study that was published this year did show benefit in relapse-free survival for those who were MRD positive pre or post-transplant, but there was not a benefit seen for those that were MRD negative at either of those time points. It should be noted, however, that the relapse-free survival was not statistically significant. And then there were studies that showed that patients who had received post-transplant maintenance with quizartinib did not derive a further benefit. So therefore, quizartinib is not indicated for monotherapy maintenance for these post-allo transplant patients. But if you'll remember back to my previous slide, quizartinib can be used for monotherapy for patients that do not go to stem cell transplant. So some examples of ongoing clinical trials in the world of AML. There's a lot of focus on menin inhibitors right now, which is a targeted therapy for patients with mutated NPM1 and KMT2A rearrangements, which if you'll remember the patient case, she did have an NPM1 mutation. So if she ever relapsed in the future, that might be a good study for her to go on. There's studies of fully oral regimens with oral azacitidine and oral venetoclax. And then there's also some ongoing research for triplet therapies, looking at combinations such as quizartinib, venetoclax, and azacitidine combined together. And that's all I got.
Thanks. I'll open up for any questions. Thanks, Allison. That was great. I was just curious, you talked a lot about targeted therapies, and every other presentation we've heard today, everybody loves to talk about the BiTEs and the CARs and how they're out there for their disease states. And I'm a little bit curious if you could talk for a second about the role that potentially BiTEs or CARs could play at some point in the future in the, myeloid leukemia space, potentially, or what they aren't playing.
You know what's interesting about that is I've heard, and I haven't confirmed this because I haven't met him yet, but one of our new physicians, Dr. Angelos, is interested in CAR in the area of AML. So I honestly don't know a lot about it, but I am curious to learn more.